Good morning, everyone. Today I'll be talking about the evolution of neck dissection and the anatomy of different nodal levels. So, one of the most important prognostic factors in head and neck cancer is the nodal staging. Uh, it has been found that the 5-year survival rates for early stage localized disease are more than 80% in head and neck cancers. However, it has been estimated that the presence of nodal metastasis can reduce this survival by 50%. And if there is extranodal extension, this further reduces the survival by 50%. Neck dissection is an important surgical procedure for the management of metastatic nodal disease. The gold standard for the nodal management has always been the radical neck dissection. But over the last few decades, looking at the morbidity of the radical neck dissection, there have been several modifications and conservative procedures have been advocated. These procedures retain certain lymphatic or non-lymphatic structures and have been shown not to compromise on the oncological safety. So, George Kreil was the first to describe the classic radical neck dissection. He was from the Cleveland Clinic, and in 1906, he described the radical neck dissection. He believed that if the neck lymphatics could be removed in a radical manner and en bloc, more cure rates could be accomplished. His thoughts were strongly influenced by Halsted, who's had done a lot of work in breast cancer. So at that time, Halsted propagated the radical mastectomy, which included removal of the breast along with the pectoral muscles and the draining lymphatics and nodes in continuity. Similarly, in the radical neck dissection, the sternocleidomastoid was removed to provide better access to the lymph nodes. So there was this analogous thinking behind head and neck and breast cancers, and this persisted for a long time, following which there were reconsiderations in breast cancer surgery, which led to reconsiderations in head and neck cancer surgery, where from radical mastectomy we moved to modified radical to breast conservation. Similarly, in head and neck surgery also neck dissection has evolved. After 1906, when Kreil had described the radical neck dissection, this was popularized by Hayes Martin in the 1940s. He described radical neck dissection as the operation to remove as thoroughly as possible from the lateral and anterior aspects of the neck the lymphatics that are likely to be involved by metastatic cancer. The photo shows the Hayes-Martin maneuver, which is commonly used for preservation of the marginal mandibular nerve, where the facial vessels are ligated, and this helps retract the marginal mandibular nerve and prevent damage to it during clearance of the level 1B. So for the radical neck dissection, the field of operation is extends from the lower edge of the mandible to the clavicle below, while anteriorly from the midline to the anterior edge of the trapezius posteriorly. It includes removal of lymph node levels 1 to 5, along with the sternocleidomastoid, internal jugular vein, and the 11th cranial nerve. Also, Dr. Martin considered routine prophylactic neck dissection as illogical and unacceptable for cancers of the oral cavity. So, this is a diagram showing the radical neck dissection. You can see the dotted line in the first figure shows the field from the mandible to the clavicle and from the midline to the anterior edge of the trapezius with clearance of the lymph nodes. On the right, you see the internal jugular vein, spinal accessory, and the sternocleidomastoid have been sacrificed, clearing the 5 levels. Then in 1967, Dr. Suarez described the functional neck dissection. This involved removal of the lymphatic tissues of the neck without removal of other anatomic structures. This was based on the anatomic description of the facial compartments in the neck. So there are two distinct facial layers in the neck. There is the superficial fascia and the deep cervical fascia. The superficial fascia is the one that envelopes the platysma and corresponds to the subcutaneous plane. And then you have the deep cervical fascia. The superficial cervical fascia extends from the zygoma down to the clavicle, enveloping the platysma and muscles of facial expression. The deep cervical fascia can be divided into 3 layers, that is the superficial or investing layer, the middle or the visceral layer, and the deep or prevertebral layer. So this diagram shows the superficial layer that is in red. Then you have the superficial layer of deep cervical fascia, or the investing layer of the deep cervical fascia, that is in blue. You have the visceral layer that covers the trachea and esophagus and the thyroid, and then you have the prevertebral layer which covers the prevertebral muscles. There is the carotid sheath or the vascular sheath that lies between the investing and the prevertebral layers of the deep cervical fascia. This facial compartmentalization allows the removal of the cervical lymphatic tissue by separating and removing the facial walls of these containers along with their contents from the underlying vascular, glandular, neural, and muscular structures. So the concept of functional neck dissection was based on this anatomy, the facial compartmentalization. In 1975, Boca popularized this functional neck dissection. This was a landmark study of his of 1200 neck dissections, where he established that a functional neck dissection was oncologically safe as compared to a radical neck dissection. In 1988, Byers et al. From the MD Anderson Hospital demonstrated that modified neck dissections was adequate for N0 or N1 necks. They even advocated that a supraomoid neck dissection for primary tumors of the oral cavity in N0 or N1 patients was adequate. However, they had a very small sample size. That's why it did not become very popular. Then there was this landmark study by Dr. Jatin Shah in 1990, which was called the patterns of cervical lymph node metastasis from squamous carcinoma of the oral cavity, where they analyzed the lymphatic spread from various subsites in the oral cavity. So this was a retrospective review where they reviewed 501 consecutive patients with primary oral cavity cancer. These 501 patients were divided into two groups. They were either clinically N0, which had 295 patients, or the clinically N plus, which had 206 patients. So the clinically N0 patients were then divided into the ones who underwent elective radical neck dissection. Those were 192 patients, and the ones who were on the wait and watch policy and underwent a subsequent radical neck dissection. The clinically N plus, everyone underwent immediate radical neck dissection. So there were three groups that they studied: the elective R&D, the subsequent therapeutic R&D, and the immediate therapeutic R&D. This study helped ascertain the prevalence and distribution of neck nodal metastasis by the levels. So they had 501 patients. 36% were oral tongue, 33% were floor of the mouth, 21% were gum, and the remaining were retromolar trigone, cheek, and hard palate. So they had majority of the patients were in stage 2 and stage 3. That is 29% in stage 2 and 36% in stage 3. Then they analyzed the chances of lymphatic mets as per the levels of the neck node. So they found that based on the three groups, there was the elective R&D, immediate R&D, and subsequent R&D. They found that the chances of lymphatics mets to level 5 was 0.5%, 4%, and 2%. They also found there was a 3% chance of mets to level 4 and 15 to 16% chance to level 4 for a N plus neck. They also studied the level of neck metastasis based on the primary tumor, and they found that in cancers arising from the gum, there was a 2% chance of level 5 metastasis. So what they found was in N0 patients, if a SOHD was performed instead of a radical neck dissection, there were 7 patients who would have had nodal metastasis left behind. That is 7 out of 192, which is 3.5%. So 6 of them had metastasis at level 4, while 1 had at level 5. Of these 7, only 3 had isolated mets beyond level 3. So they found that only 1.5% of the patients had skip metastasis beyond level 3 in a clinically N0 neck. And in N plus patients, they found that if levels 1 to 4 had been cleared, then 3.2%, that is 10 out of the 324 patients, would have had nodal metastasis left behind at level 5. So what they concluded was that the highest risk of metastasis from the oral cavity was to levels 1, 2, and 3. And the risk of metastasis at level 4 in an N0 neck was 3%, while in an N plus neck was 15 to 16%. And they found that if there was a level 5 metastasis, that was always associated with nodal mets at one of the preceding levels. Now there is sentinel lymph node biopsy that has come up. It is very popular in other cancers like breast cancer and penile and melanoma is where it's very popular. It's not as popular in head and neck cancers as of now. So there is no imaging technique that is able to detect small or microscopic subclinical mets. So taking into account the limitations of palpation and imaging, there are still about 30% patients who will be staged clinically N0 who will end up having occult metastasis if their neck was actually dissected. The procedure of a sentinel lymph node biopsy is there is pre-op peritumoral injection of a radiotracer, following which you do a lymphoscintigraphy using SPECT CT. This allows marking of the sentinel lymph node on the skin, and then the sentinel lymph node can be removed using with the help of an intra-op gamma probe. And this lymph node is then sent for histopathological examination, which is done meticulously. So there is evidence stating that sentinel lymph node biopsy is safe and can be done. There is this CentiMER randomized control trial which compared elective neck dissection versus sentinel lymph node biopsy, and they found at the end of 5 years the neck node recurrence was similar amongst the two groups. That is 89.6% versus 89.4%. Also, the loco-regional free and disease-specific and overall survival were comparable in the two groups. That is why sentinel lymph node biopsy is now incorporated as a diagnostic staging method in the NCCN guidelines. But there are certain limitations of the sentinel lymph node biopsy, and that is why it's not widely used as of now. First is most importantly, in previously treated necks, you cannot use sentinel lymph node biopsy, whether it's operated or radiated, because there is aberrant lymphatic drainage. Sentinel lymph node biopsy will not pick up soft tissue deposits. Then there is this phenomenon known as the shine through phenomenon that is seen in floor of mouth lesions. Basically, when you inject the dye at the primary site in the floor of the mouth, that may be picked up in the neck because of the proximity of the two, which may then affect your actual detection of the sentinel lymph node. Also, with the sentinel lymph node, the sentinel node is sent for final histopathological examination. So if it comes out positive, there is a need for a second stage surgery, and there is a long learning curve of this procedure. So that is the evolution of the neck dissection. Now I'll speak about the different cervical nodal levels. So at the MSKCC, Dr. Jatin Shah in 1981 introduced the concept of the levels of these neck nodes. As we know, there are 6 levels in the neck, which are divided based on various anatomical landmarks. So you have level 1A, which is the submental group. So level 1A is the submental group that is bounded by the anterior belly of the digastric on both sides and inferiorly by the hyoid bone. Then you have the submandibular, which is 1B, that is bounded superiorly by the mandible, anteriorly by the anterior belly of digastric, and posteriorly by the stylohyoid muscle. Then you have levels 2, 3, and 4, which are the upper, middle, and lower jugular. They are divided, level 2 extends from the skull base to the hyoid bone. Level 3 extends from the hyoid bone to the cricoid cartilage. And level 4 extends from the cricoid cartilage to the clavicle. Level 2A is also divided into A and B based on the spinal accessory nerve. Level 2A is anterior to the spinal accessory nerve. Level 2B is behind the spinal accessory nerve. Then you have level 5, which is the posterior triangle lymph nodes. Level 5 extends anteriorly, it is from the posterior part of the sternocleidomastoid muscle posteriorly to the anterior part of the trapezius. And it extends from superiorly from the convergence of the trapezius and sternocleidomastoid to inferiorly till the clavicle. It is divided into 5A and 5B by the inferior part of the cricoid cartilage. And then you have level 6, which is a central compartment, which is important in your thyroid cancers. This extends from the hyoid bone to the suprasternal region, and it is located between both the common carotids. So based on the primary site, there are these lymph nodes which are most likely to be affected. So you have the oral cavity, which is most likely to spread to levels 1, 2, and 3 first. The larynx or pharynx would spread to the jugular chain, which is levels 2, 3, and 4. The thyroid would spread to level 6, 7, which is superior mediastinal, and level 4. Parotid would, the first echelon nodes for the parotid would be levels 2 and 3. And for the submandibular and sublingual glands, it would be 1, 2, and 3. So there is this classification that has been given by the American Academy of Head and Neck Surgery, where they divided the neck dissections into 4 types. First is the radical neck dissection, which is the standard procedure. And the other subtypes are all modifications of this. Then you have the modified radical neck dissection, which involves preservation of one or more non-lymphatic structures. So it's either the preservation of the sternocleidomastoid, internal jugular vein, or spinal accessory nerve. The third type is extended radical neck dissection, where apart from the structures removed in the R&D, there are some additional lymphatic or non-lymphatic structures that can be removed. And the fourth is selective neck dissection, where you preserve one or more of the lymph node groups that are routinely removed in the R&D. So the first 3, that is R&D, MRND, and extended R&D, are together called as comprehensive neck dissection. There are 3 types of modified radical neck dissection: type 1, 2, and 3, based on the structures that are preserved. In type 1, you preserve only the spinal accessory nerve. In type 2, you preserve the internal jugular vein and spinal accessory nerve. And in type 3, you will preserve the sternocleidomuscle, internal jugular vein, and the spinal accessory nerve. But presently, these different nomenclatures are not used. What is recommended is that it is called neck dissection, followed by the nodal levels and structures that are to be removed. So suppose you're doing a supraomohyoid neck dissection, you call it as neck dissection 1, 2, and 3. Suppose you're doing a modified radical neck dissection type 1, where you only preserve the spinal accessory nerve, you would call it neck dissection 1, 2, 3, 4, 5. And since you're removing the IJV and sternocleido, it will be 1, 2, 3, 4, 5, IJV and SCR. That is how it is described. That you should be describing your neck dissections like this now. Also, there is these AGCC recommends that for adequate staging in a radical neck dissection or modified radical neck dissection, there should be at least 10 lymph nodes removed. While in a selective neck dissection, there should be 6 lymph nodes that should be removed. That is the minimum lymph node yield that is recommended. In conclusion, neck dissection is the standard therapy for patients. The R&D is now replaced with more conservative surgeries, that is the modified neck dissection or selective neck dissection for node positive disease. The use of frozen section can help guide the extent of neck dissection, where you can decide based on levels 1, 2, and 3 whether you need to go further for oral cavity cancers. And this can help reduce the morbidity of surgery without compromising on regional control rates and survival. Any questions? You want to lead the discussion? You have a negative predictive value and you have a recurrence pattern. Following elective neck dissection, the recurrence pattern is 16%.
That means even when you do a dissection in occult neck in 16 patients out of 100, you will fail. And that is similar to a sentinel node biopsy. So that means you might not pick up that node which was there as a occult disease and follow up the patient. So today's recommendation following a sentinel node biopsy is if you pick up a positive node, you need to do a complete neck dissection. That is the standard of care. So please add that because that comes as the guidelines. When you mention that it is a guideline, the reason and what we need to do if you pick up a positive node. And we need to know that there are now meta-analysis which are looked at all the three studies. There's an Indian study as well. So all the three studies have been analyzed, and we know that this is, I think, by HPAL. So we put that into perspective so that we get a better idea about what is the evidence. I would urge you all to put up these studies because all this is old literature. But what is the recent literature on which you're basing your current guidelines? That will help.
In level 7 also has been added superior mediastinum, which was not mentioned.
So, what about the skip metastasis? Still obsolete or still truly believe skip?
So there is data saying that skip metastasis to level 4 and 5, less than 5% cases, and also to level 2B is about 3 to 4%. This is and usually so usually the pattern is if you have metastasis at level 1 to 3, uh, then only you will get metastasis in rare cases. So usually in tongue cancer, it's when you consider doing levels 1 to 4 instead of just 1 to 3 because there's a higher chance of skip metastasis in tongue cancer.
So there is no evidence that there is a skip metastasis. So earlier paper which was there, which looked at the skip metastasis, and they said you should do a level 4. So large studies, retrospective studies, there's even one from Tata Hospital looked at level 4 and 5. The incidence is extremely low in NZ. So you would clear one more echelon node after your positive node or not, but suspect occult disease. So it's not making sense to add level 4 or 5 in occult in NZ clinic. Even in the N plus neck, as he showed, that it is less than 3%.
I'm late, but I have a small question.
Yes.
How often do we electively do bilateral neck dissection?
So there is data that has found that there is about in tumors that are crossing the midline, there is a 25% chance of contralateral metastasis. So usually in tongue cancers, floor of the mouth, lower, anterior lower as well as when it is crossing the midline, that's when we do it, unless preoperatively picked up on imaging.
So electively, you still plan whether the imaging shows.
In an N plus neck, there are studies which have shown that if you have a skin involvement and if you have multiple level nodes and if you have extracapsular spread, these three criteria you should do the contralateral neck. Because then the radiation therapist will cover the contralateral neck. And we know that levels 1B, 2, and 3 are at highest risk in the contralateral. Even in the N0, the reason why we are trying to go towards central node is the patients that have got lesions reaching midline or at the tip or at the base tongue. They have more than 5% incidence of contralateral metastasis. So you may have an ipsilateral completely negative. So the first lymph node SLNP that we did at Tata, we picked up a contralateral node. The patient had lateralized lesion but towards the dorsal lingual surface. The patient threw a contralateral one. And that would never have been picked up because you would have done only an ipsilateral.
Do we label that as skip metastasis?
No, that's a normal lymphatic drainage. So lymphatic drainage of that that patient was going towards one of the other contralateral. So this will be picked up on the central node. So when we start off here with the nuclear medicine, this is something we should go ahead with because breast cancers and head and neck both require central node.
Sir, for the reaching midline, sir, how much distance will be considered for the reaching midline from midline to tumor the 1 to 5 mm or 5 to 10 mm?
Reaching midline is towards the paramedian center.
So,
So there is no, I'm not sure if there's any distance mentioned. But when you're looking at lateralized nerve cancers, we are looking at tumors that are coming onto the hyoglossus muscle.
Yeah.
When they involve the genioglossus muscle, which is a median or paramedian structure, you would have the contralateral involvement. So if you look at the MRI and you know that it has crossed the lateral septum, coming onto the genioglossus bundle, you will want to consider contralateral.
So there's a question on chat that when to choose for removal of level 1B along with primary, and if taken separately, will it make any difference?
So as such, it will not make a difference. It depends on whether you're doing a mandibulectomy. You may sometimes take out the level 1B with the primary tumor. It will not really make a difference. Sometimes when nodes with cross perinodal extension are there, it may be safer to take it out with the primary tumor.
I agree. I think if the tumor is not the nodal disease or mandibular gland is not stuck to the underlying mylohyoid or the digastric, you can take it out as a separate. The earlier concept of doing a combined oromandibular neck dissection is no longer there, the so-called command. So we are now doing disparate dissections and we are doing level-wise dissection. But I think the most important consideration is to maintain the facial plane.
So in case of unknown primary neck test, what we are doing to body cut or we remove all the.
So in an unknown primary, usually we would do levels 1 to 5 because it's an N plus and we are not sure of the primary. Then we would do levels 1 to 5. We would clear.
And contralateral?
Only ipsilateral, ipsilateral 1 to 5.
Even if it's N3, like if it's an N3, it is.
Usually what we follow is just ipsilateral 1 to 5 because you would then also be using adjuvant treatment.
So by the same consideration, you might want to consider the contralateral neck, but generally the nidissectomy, as they would call it in unknown primary, you remove only the node because you don't know where the primary is coming. So we would generally have done a PET scan, and with that we would have picked up any activity on the contralateral side. So if there is something and you're contemplating surgery, then you would address both. If there is nothing, the negative predictive value of a PET scan is 96% and above. So we know that there is no activity unlikely to harbor a disease which is more than 4 millimeters because the PET uptake is about 4 millimeters. So you would not do it if there is no PET activity.
And so if you're considering like ultrasound versus in N0 next, we know that N0 is clinically, that's probably radiologically. Then we're doing a sentinel lymph node and then there it's coming positive. So then what is the difference in the, if that, I mean, that's probably
Difference
how,
in the
like the sensitivity of why is ultrasound falling short and SNLP like picking up those lymph
No, so basically, it is sentinel node. We are just picking up that node, which is the first secular node. Then in the biopsy, we are getting an histological diagnosis. So USG, if you see the literature, USG guided FNAC has got a better sensitivity and sensitivity than USG alone. So sentinel node also you are taking use of two modalities. One is a gamma that scans, SPECT scan, and you are taking the use of a pathologist. That's why the yield is better, and you are able to get the like whether it's metastatic or.
So I
So
understood
in
that.
ultrasound, you are looking at structural changes in the lymph node to know whether that is a metastasis or not. In a sentinel node, you're just doing a lymphatic mapping. There's a difference. So I'm just doing a lymphatic mapping and seeing where is that first echelon coming up, where there is a radiocolloid uptake. And it will have an uptake because of a disease process rather than no disease. So if there is disease and there is a lymphatic pathway tracing up to that point, that node is picked up. Not because it is positive on ultrasound or anything.
Ultrasound it never really helps in picking up second.
Yeah.
To sense. We know that only by distribution pattern that we could go here. That's why we focus there. I don't think so. The sentinel concept is very vague for us because we don't understand how it would be behaving.
Right. So we are using two methods. One is the radiocolloid dye, and one also is the color. Radiocolloid and dye, two methods. So we either use methylene blue, and now we are moving on to ICG, indocyanine green. So when we use these two, we are combining the effort of the lymphatic being mapped by the radiocolloid as well as the dye. So the difference, I think, is the actual pathway versus a change structure. Because we know that from other studies from Europe, where we first started doing Van den Brettel's group, that the lymph node ultrasound sensitivity was higher when the node was positive. When it's a negative node or not involved, the yield is very low. Our paper from Tata has the yield in the end connect. And our own study, the published data from it, yield is very low. So the yield of a node which is a heavy population, we have to rely on our paper that just mute.
Done.
There was a recent paper that looked at CT scan and ultrasound, and CT scan with ultrasound has a better yield.
Because of the extra capsules plate picking up one and the retropharyngeal, we should tend to miss an ultrasound. Medius also for that matter. These two modes are getting beyond the ultrasounds. Ultrasound has one advantage. You can add side by side effect. So before I think you're doing dissection, if you do quick through FNC, that's what really helps.
So is there an advantage using better probes now that you all have much better probes? All this data is with older generation ultrasound.
Because you tend to see the architecture better. So the fact is, even a small node can have a very small focus. If we are lucky to pick that up, I think we'll be adding to sensitivity. That's how we do that. So it is purely analytical information. But there is a newer kind of vascularity, microvascular flow, that gets displaced better, that can show abnormal flow. And the node which would have passed as normal, maybe nowadays we are trying to look at it different. But still, I think if any adding is the thing. So our general understanding is when there is a planned dissection and we pick up abnormality, we generally are relaxed. When it is not planned and we pick up something, then we are restless. Then we feel like doing it.
Then you would call it as an indeterminate.
And we expect them we should be allowed to do FNC, which is what generally we are allowed, so we do it.
Yeah. So generally in our practice at TMH was also, if you had told me it is indeterminate, we would explain to the patient about possibility of surgery with more confidence. So if it was a 1 millimeter node, 1 millimeter tumor depth, and you are looking at whether to operate or not, and you tell me there's an indeterminate, I would be more convinced that I should operate this patient. But today recommendation are independent of the depth and size, you need to do the neck. Because
that's for SCC, right?
SCC, this is SCC. So the SEND study which Kanav put up, that showed that even with millimeter, less than 3 millimeter depth, the same occult metastasis rate exists. It's about 27%.
So then do you need imaging in that sense?
We don't know. Because a lot of patients refuse neck dissection. They're not convinced that you should do it. And truly, 70% we don't need to do. So I think the middle path would be to do something like a sentinel. But because of logistics and cost issues, we are not doing it.
But this is my just general observation. Maybe I've been been seeing Dr. Pradhan's sir's patients for some 30 years. So out of that, 20 years we're doing kind of. Previously, they were quite selective, looked quite reasonable because we used to follow them for 5 years down the line and just not have metastasis. But the smaller nodule nowadays also tend to show that there are metastases. I don't know, and this is a very broad.
As in an occult disease.
No, not occult. In the sense, previously we used to see